Last time we talked about basic renal processes in the nephrons of the kidney that include renal blood flow, that include glomerular filtration process, and include tubular reabsorption process and tubular secretion process. All these renal functions should be evaluated in medical laboratory, and to have a good evaluation we need a detailed understanding for the physiological functions related to these processes. Also, we talked about renal blood flow, and we have a conclusion that about 1,200 ml of blood per minute will be filtrated in the nephrons of the kidney. Also, we have a diagram for the blood flow through the nephrons of kidney that will start from the afferent arteriole and then in the glomerular arteriole and then efferent arteriole, vasa recta, and peritubular capillary. This is the renal blood flow that will be effective for the filtration and reabsorption process for the different solutes found in the blood and filtrate. Also, we talked about glomerular filtration process. We said that the glomerulus has a specialized structure composed of basement membrane, endothelial cells, and we said these cells has a special structure because it is fenestrated. It has small pores inside of it to facilitate the filtration process. Also, we said the glomerular structure has a podocyte structure, something like a visceral epithelium. Also, we said that glomerular structure has a special function to prevent the filtration of protein by having something called negative shield. This negative shield will preserve negative protein structures like albumin and prevent their filtration. Even they are small in structure, the negative shield will prevent the filtration of these protein. So by this special structure of the glomerulus will prevent the filtration of proteins, large cells, but at the same time it will allow most of the soluble solutes to be filtrated in the Bowman's capsule and in the Bowman's space for the function of the filtration in the kidney. We talked about glomerular filtration and the glomerular pressure that is necessary for this process. We said the glomerular pressure need hydrostatic pressure and oncotic pressure. The hydrostatic pressure will push the blood from the blood circulation to the Bowman's space. At the same time, the oncotic pressure will be responsible for the movement of water from Bowman's space to the blood flow. But finally, the final pressure from the vascular space will be larger to push the blood inside of the Bowman's capsule. And by this, there will be a 200 liter per day that will be filtered in the Bowman's capsule. Of course, this will be processed more, and finally we will have only 1.2 liter, about 1.2 liter of urine per day. We have the renin-angiotensin system as an important system to control the blood pressure. This system will prevent the decrease in the blood flow through the nephrons. So if there's a decrease in the blood flow, there's a low blood pressure, low plasma pressure. This will stimulate a production of a specialized enzyme called renin enzyme. This enzyme is produced from a specialized cell called Jocasta glomerular cells. Those in purple color here. Those cells will be responsible for the production of renin enzyme. These cells found between distal tubule and efferent arteriole. It will sense the change in the blood pressure. If there's a decrease in blood pressure, juxtaglomerular cell will produce renin enzyme that will convert angiotensinogen to angiotensin 1. Angiotensin 1 will circulate in the blood and it will be converted by a specialized enzyme called angiotensin converting enzyme to angiotensin 2. So finally, if there's a drop in the blood pressure, the renin enzyme will result in the formation of angiotensin 2. Angiotensin 2 has multiple function. It's like the vasoconstriction. As an important part of the vasoconstriction process, it will be responsible for the decrease in the diameter of efferent arteriole in the nephrons of the kidney, and this will increase the blood pressure inside of the nephrons, and this will result in the more capacity for the filtration of the blood, even if there's a drop in the blood pressure. Also, it will be responsible for proximal tubule sodium reabsorption. Another function for the angiotensin 2 is the production of aldosterone hormone. Also, some studies say that angiotensin 2 also stimulate the production of ADH hormone. So aldosterone hormone and ADH hormone will control the electrolyte balance. It will control the blood flow and the blood volume, and this will prevent the drop in the blood volume and control the blood pressure in the kidney. You have in table 2:1 actions of the renin-angiotensin system. It's composed of 4 steps. You have to evaluate it and study it and memorize all of them for the complete study of this renin-angiotensin system. Now we will talk about a new function in the kidney that is called tubular reabsorption. Tubular reabsorption is very important. As we said before, in the glomerular filtration process, kidney will filtrate all of the solutes found in the blood. Even it will prevent the filtration of cells and protein, it will allow the filtration of very important solutes like sodium, urea, glucose, amino acids. All of these solutes will be filtrated in the Bowman's capsule. So the kidney need a system or mechanism for the tubular reabsorption. This mechanism is called tubular reabsorption. This tubular reabsorption process will be responsible for the different processes of reabsorption. It will start from the proximal tubules of the kidney and distal tubules of the kidney, and finally the collecting duct system that will be responsible for the reabsorption of water in the kidney. So these important systems in proximal tubules, distal tubules, collecting ducts will be responsible for a complete reabsorption process that will preserve important solutes from the loss in the urine. In this table, we have a detailed mechanism for the tubular reabsorption. You have to memorize all the elements in this tubular reabsorption system. The tubular reabsorption is composed of active transport. Active transport need energy. It will need ATP for the reabsorption process. So it has a limited function. It is not effective for the reabsorption at high concentration, and we will have a definition for this process. Active transport include glucose, amino acids, salts, chloride, and sodium. It has different functions and different sites for this process. We have the proximal tubules, ascending lobe of Henle, and the proximal tubule and distal tubule for this process. So the active process for the reabsorption of these solutes will need energy in different sites. It will preserve these solutes from the loss. Also, we have a mechanism of passive transport that will transport water, transport urea, sodium without need for the energy. It will also depend on the natural osmotic pressure to move the solutes from the large concentration to the smallest concentration. And this will include water, urea, sodium. Proximal tubules and descending lobe of Henle and collecting ducts will be responsible for the reabsorption process. Urea will be reabsorbed in the proximal tubules and ascending lobe of Henle only with sodium. Now, something related to tubular reabsorption is the maximal reabsorptive capacity. Let us have a definition for this term, maximal reabsorption capacity. The definition is maximum reabsorption ability for solute by renal tubules. So this is the definition for the maximal reabsorptive capacity. The maximum reabsorption ability for solutes by renal tubules. Let us have an example, and this is the most common example in medical analysis, is the concentration of blood glucose. Patient with diabetes will have elevated glucose. The elevated glucose in the blood cannot be reabsorbed after the filtration at a specific concentration. So the kidney has a specific capacity for the reabsorption of glucose. So we will need another term for definition using this example called renal threshold. Renal threshold is defined as a plasma concentration of a substance at which active transport stop and increased amount are excreted in urine. This is called renal threshold. Let us have an example. Renal threshold for glucose, it is about 180 milligram per deciliter in blood. So this is the renal threshold of the kidney for glucose. If glucose above 180 milligram per deciliter, glucose will appear in urine. So this is the idea. The renal threshold reflects a plasma concentration of a solute that at which kidney will not be able, above this concentration, kidney will not be able for further reabsorption of this solute. So we can use this example for the renal threshold always in medical laboratory. So we have another examples, another physiological term that we should understand, something called countercurrent mechanism that is related to osmotic gradients. A selective urine concentration process in the ascending and descending lobe of Henle. The aim of this process is to make filtrate more concentrated, and the medium around the tubules of the kidney will be able to reabsorb more water from the tubules of the kidney by making the medulla medium highly concentrated, and by preventing the water impermeable walls of the ascending lobes. Let us have this figure for more explanation. The countercurrent mechanism is one of the parts related to the reabsorption process. In this process, the descending lobe will have the ability for the reabsorption of water. Now the medium around the tubules will be less concentrated, and to prevent this and to prevent the loss of the ability for the reabsorption of water, the ascending loop will prevent the reabsorption of water, so no water will be reabsorbed in the ascending loop. Only the chloride and the sodium will be reabsorbed in the ascending loop of the kidney. Okay, so we will have a very concentrated area. Look for the concentration, about 1000 milliosmol. This is a highly concentrated area. So this will be a good medium. In the next level, at the time when the filtrate reaches to the collecting duct, the water will be able for reabsorption according to the needs of the aldosterone hormone and ADH hormone. So we will summarize it in the following method. A countercurrent mechanism is a mechanism to ensure the continuous reabsorption of water in the nephrons of the kidney. To do this, the descending loop of Henle will have the ability for reabsorption of water, but the ascending loop will not be able for the reabsorption of water. This will make the medium around the tubules more concentrated, and this will allow the collecting duct for the reabsorption process of water. So this is another physiological example of the function of the tubular reabsorption of the solutes. Now we will talk about the function of ADH hormone, that is called antidiuretic hormone. This hormone is very important to control water level in the blood. The hormone produced from a specialized site in the pituitary gland according to the osmolality of the blood. If there's an increase in the body hydration, this hormone will not be produced, it will be inhibited, and this will increase the urine volume. And at the time of the decrease of the body hydration, of course, ADH will be increased and urine volume will be decreased. So this is an example of how our kidney can control the amount of urine excreted depending on the production of antidiuretic hormone and countercurrent mechanism and other mechanism for the tubular reabsorption. Now we will talk about another function of the kidney that is called tubular secretion. Tubular secretion means the passage of solutes from the blood in the peritubular capillary to the tubular filtrate. Look for this curve. When the filtrate move from the site of the tubules to the blood, this is called reabsorption. When the solute move from the blood in the peritubular capillary to the tubular site, this is called tubular secretion. So this is the mean of tubular secretion. Tubular secretion is important for the elimination of waste products that is not filtered by the glomerular filtration. Another important example is the elimination of drugs in the urine. And another function for the tubular secretion is the regulation of acid-base balance in the body. If the kidney is able to regulate acid-base balance, this will be done by the tubular secretion process. To understand the tubular secretion process, we have to understand some figures. Let us start with the first figure about the reabsorption of bicarbonate, an important part for the control of the acid-base function in the kidney. We have three components. The first one is the tubular lumen. This is the lumen where the filtrate will follow. We have the renal tubular cells that mostly will be a proximal cell. And finally, we have the peritubular plasma. As we said before, movement of the solutes from the peritubular plasma to the tubular lumen, this is called tubular secretion. Movement of the solutes from tubular lumen to peritubular plasma, this is called tubular reabsorption. So to understand the role of kidney in the control of acid base, we have to understand first the reabsorption of filtered bicarbonate. For the process of the reabsorption of bicarbonate, the process will start on the movement of the CO2, released CO2 in the tubular lumen to inside of the proximal tubule. That is will be converted to another time to bicarbonate, and bicarbonate will go inside of the peritubular plasma. This is the effective method for the movement of bicarbonate in the tubular lumen to the peritubular plasma. So the conversion of CO2 inside of the tubular lumen and movement inside of the renal tubular cell will result in the formation of bicarbonate. At the same time, you can notice that we can do a secretion for the hydrogen ion inside of the tubular lumen. Now we will talk about excretion of secreted hydrogen ions combined with phosphate. This will explain the role of the kidney for the tubular secretion of some solutes. How the kidney has the ability for the solute secretion in the urine. Let us start this time from the CO2. CO2 found inside of the blood. The CO2 will enter through the renal tubular cell and bind with H2O to form carbonic acid. Carbonic acid will be transferred to bicarbonate. Bicarbonate, as we said before, it will be reabsorbed by the peritubular plasma. At the same time, the hydrogen ion this time can be excreted in urine, and the elimination of hydrogen ion will control the acid-base balance by the movement of hydrogen ion inside the tubular filtrate and binding with phosphate ion found normally in the filtered plasma. This will form the dibasic form of phosphate, and this can be filtrated in the final urine. So the kidney has the ability for the tubular reabsorption of hydrogen ion using this technique. It will use phosphate ions for the buffering process to release hydrogen ion from the blood to the urine to control the acid-base balance. Excretion of urine can include also the hydrogen ion combined with what? With ammonia. So we can use also ammonia for the process of the excretion of hydrogen ion. This process is similar to the previous process. The CO2 found in the blood. The CO2 will move inside in the renal tubular cell, and it will convert it to bicarbonate and hydrogen ion. Bicarbonate will move by reabsorption to the peritubular plasma, and hydrogen ion will be excreted in the tubular lumen. This time, the solute that can buffer this hydrogen ion and facilitate the excretion and secretion of these solutes is ammonia. Ammonia can be released from glutamine amino acid found inside of the renal tubular cell. Glutamine cell will have the responsibility for release ammonia. The ammonia that is produced will release to tubular lumen, and this will form the ammonium that can be released in the final urine. So another buffering system for the hydrogen ion excreted in the tubular lumen is the ammonia. So phosphate and ammonia, both of them can be responsible for the secretion of hydrogen ion in urine. If there's any change in the ability of kidney to do this, the patient will have a pathological condition, and we understand more about this in the next explanation. Now let us talk about a new section. It is the renal function test. How to evaluate the renal function process that we have talked about. How to evaluate renal blood flow, tubular reabsorption, tubular secretion, glomerular filtration. We have many laboratory tests in the lab that can be used for the evaluation process. We have the most important is the clearance test. Clearance tests include a group of tests. Currently, we will use creatinine clearance test to evaluate glomerular filtration. Also, we can have many other laboratory tests to evaluate the function of kidney. We have something called osmolality test. The old terminology is osmolarity. The current terminology is osmolality. Osmolarity can be useful for the evaluation of a tubular reabsorption. Another test that can be helpful for the evaluation of the capacity of the kidney to reabsorb water and to work sufficiently, something called free water clearance test. So this test also will be responsible for tubular reabsorption. And this is of course for the evaluation of the distal tubule function and tubular reabsorption. Another test that can be used to evaluate the kidney tubular secretion, as we said before, is the measurement of ammonia. Formation of ammonia is very important for the tubular secretion. Also, we have another test to evaluate the tubular secretion. It's called titrable acidity. Titrable acidity is helpful to evaluate the amount of acid in urine and the ability of kidney to excrete acid. Also, we have a test called para-aminohippuric acid test. This test has a benefits for the measurement of renal blood flow. So this test also is very important to evaluate the renal blood flow. In the next explanation and in the next figures, we will understand all these renal function tests, what we have to do to understand them, to calculate them, and how we can apply them in medical laboratory. Now we will talk about glomerular filtration test. We need a standard test to measure the filtering capacity of the glomeruli that is called clearance test or glomerular filtration test. The clearance test should have some properties for the evaluation of the glomerular filtration. The first thing, it needs to measure the rate at which the kidney are able to remove a filterable substance from the blood. And the substance analyzed must be not reabsorbed and not be secreted. So we need an analyte that only filtrated by the glomerular function and not reabsorbed and not secreted by the kidney. To do this, we need it also to be stable during long collection, like 24-hour collection. Also, it should have a constant concentration in the blood, and we need also laboratory test for the evaluation. So the clearance test has some properties that should be included for the selection of a glomerular filtration test. In the older methods for the evaluation of clearance, usually scientists used urea for the evaluation, but we have a problem that more than 40% of the urea will be reabsorbed. To be able to use it for a clearance test, we have used some correction factor, and also blood patient have excess hydration for the evaluation of a clearance test. Because of this problem, that urea will be affected by hydration of the body, and the reabsorption of the kidney for urea that change according to the body hydration situation. Now we are not using the urea for a clearance test. As a standard test for the evaluation of a clearance, scientists used inulin. Inulin is a polymer of a fructose. If it is injected from an exogenous site, it is extremely stable substance that can be filtrated in the glomerular function without reabsorption and without secretion. So it is a standard test that can be used to evaluate the clearance of the kidney ability. The problem with this test is it is difficult to be performed. The patient need an entry to a hospital. It will need to take the exogenous inulin in a specific concentration, and after this we need to collect urine for a long time for the evaluation of the clearance. So this test can be considered as a good standard test, but it is difficult to be implemented routinely in medical laboratory. Now we will talk about the most current and the most usable test to evaluate the clearance test. This test is called creatinine. Creatinine is a waste product of muscles. This is very important. We know the source. Found in a relative constant rate in the blood. This means creatinine usually in the blood is stable. If we measure a sample at morning or at the evening, it will be the same concentration. So the production is constant according to the muscle mass function. The routine endogenous procedure to evaluate the glomerular filtration, this is the current method for the current evaluation of the creatinine in urine. It has some disadvantages. You can read it in the book, but those disadvantages will not prevent us from using as a routine test for the evaluation of glomerular filtration. Even for the presence of this disadvantage, we have many advantages for the measurement of creatinine as an effective test for the evaluation of clearance of the kidney. Now we will have this question: how to calculate a clearance of creatinine for the evaluation of glomerular filtration. We have many components for the calculation. Let us understand these parameters. U mean the concentration of creatinine in collected urine. V is the volume of urine. V can be calculated easily. V is equal to the total urine volume divided by the time for collection. So if we use this formula, we can calculate V. B, it's the creatinine concentration in plasma or blood. So these three parameters can be measured to calculate creatinine clearance to evaluate glomerular filtration process. Because creatinine production in the blood dependent on a muscle mass size, we can use a correction factor for the body surface area. Body surface area divide 1.73 on the area of the body. We have some nomograms that can be used for the calculation of the body area. The body area can be calculated depending on the weight and in the height of the body. We can use nomograms or some formulas in online or Excel sheet to calculate this area. So the idea from the body surface area conversion factor is to have a standard result for the patient, even if the muscle mass is different from one patient to another. So this formula, you have to memorize it carefully and you can apply it for the calculation of the clearance of the creatinine in urine. The normal range also it is included to be memorized. The normal range is from 107 to 138 in ml per minute in male, and 87 to 107 ml per minute in female. So remember these numbers as a normal value for creatinine clearance. This figure shows the creatinine amount in the blood is equal to the creatinine amount in urine. The benefits of this, you can calculate the amount of the glomerular filtration using creatinine as an analyte found in blood and in urine. So you can calculate the glomerular filtration using these parameters. Let us have this example. Urine creatinine was 120 milligram per deciliter, and as we said before, this is the U. Plasma creatinine was 1 milligram per deciliter, as we said, this is B. And urine volume was 1440 ml of urine. That is collected in 24 hours. The first step to calculate the creatinine clearance and to evaluate the function of the glomerular is the calculation of volume. Calculation of volume can be done by dividing the total volume of urine per 24 hours. Now we have to convert hours to minutes by multiplying minutes and hours, and we will have 1044 minutes, and this is equal to 1 ml per minute. So the volume of urine divided by time in minutes, this is called V. Now we can apply the formula. We can multiply U in V divided by the plasma concentration of creatinine, and this will be equal to 120 ml per minute, and this is normal for a male, of course. As we said before, the male will be from 107 to 138, so these numbers are normal for a male. These nomograms can be used to calculate body surface area. If a patient has a low weight or high weight, we have to correct the results of creatinine clearance by using the body surface area. If you want to use this nomogram to calculate body surface area, it is easy. You can connect, let us assume that the patient height is 170 and the patient weight, let us say in kilogram, 70 kilograms. So you can connect to these points like this. Of course, you need a more accurate line. Okay, the number you have here is the body surface area. You can use this nomogram as a manual method. Of course, as I said before, you can use Excel sheet or some formula or some online websites to calculate the body surface area directly without this method. So this is the idea how to calculate body surface area using nomograms. You will use height and body weight to calculate body surface area. So the correction factor will be 1.73 divided by the body surface area. This will have a correction factor that can be multiplied with creatinine clearance for correction. So if a patient has a low weight, this factor will elevate the result, and if the patient has a low weight, if the patient has a high weight, this factor will decrease the result to be corrected like the standard results of the patients. There are other formulas that can be used to calculate for creatinine clearance without the use of urine parameters. An example is MDRD formula. You can evaluate it and read about it, but it is not included in the exam for the calculation. So this is a self-reading formula. Also other formulas in the book, you can read about them. You can use it to calculate creatinine clearance using only creatinine and some patient parameters. There's a debate about these formulas, which is accurate and not accurate. So we will remember the basics of the calculation of the creatinine clearance that we talked about previously. As a method to calculate a clearance test, we can use also beta 2 microglobulin in the blood. Beta 2 microglobulin can be used to evaluate the clearance test of the kidney using only single test in the blood that is called beta 2 microglobulin. Beta 2 microglobulin is found on the cells and produced at a constant rate in the blood and should be filtrated and excreted in the urine. Any change in the kidney function will increase the level of beta 2 microglobulin as a solute found in the blood as a biochemical structure, and the elevation of beta 2 microglobulin can be related to clearance test. So this test is good, fast, have good results for the elevation for the change in the kidney, but the problem with this test, it is not effective in cases of malignancy or patient has an immunologic disorder, because in cases of malignancy or immunologic disorders, the beta 2 microglobulin will be produced at a higher rate and it will be elevated in the blood circulation, and this elevation is not related to kidney function, so it is not effective for these cases. Another modern test that is used for the evaluation of clearance test, something called cystatin C. This small protein also produced by the cells, by nucleated cells, and this protein should be cleared by the kidney in the urine. Any elevation of cystatin C in the blood may indicate a change in the kidney function that is related to clearance test. This test now can be considered effective to evaluate pediatric function, diabetic cases, elderly patient, critically ill patients. So this test now has a good results for the evaluation of kidney function without the need to collect blood and urine creatinine calculations. Now we will talk about tubular reabsorption test. After we finish the method to evaluate the glomerular filtration using creatinine clearance, cystatin C, beta 2 microglobulin, other formulas for the creatinine, now we can talk about tubular reabsorption test to evaluate the ability of kidney to work normally for the tubular reabsorption. Let us have this review. Tubular reabsorption usually is the first function to be affected in renal disease. So it is an early marker compared with the glomerular filtration. In glomerular filtration, kidney will lose more than 50% of its function before the change in the parameters of glomerular function. In contrast with tubular reabsorption function that will be changed immediately as an early marker for the change in the kidney function. This test usually determines the ability of kidney to reabsorb the essential salts and water. So it will measure the ability of the kidney to concentrate urine. If the patient have a normal concentration ability for urine, the tubular reabsorption will be normal. If the ability of kidney to concentrate urine is lower, this will result in an abnormal results for tubular reabsorption. To do so, we have some laboratory tests to evaluate the tubular reabsorption. The first one is called osmolality, and the second one specific gravity. Osmolality and specific gravity are used in laboratory to evaluate the ability of kidney to concentrate urine. Osmolality usually more specific to evaluate the ability of kidney for tubular reabsorption, because the specific gravity is affected by the sites of the solutes found in urine. So urea found in urine contribute more to the specific gravity compared with sodium with a small structure. But in case of osmolality, the osmolality will not be affected by the size of the solutes. It will be affected only by the number of solutes found in urine. At the same time, we use both of them to evaluate the function of tubular reabsorption. Specific gravity can be used for screening in routine urine analysis. Osmolality can be used as a more specific test to evaluate the ability of kidney to concentrate solutes, and it can be measured in blood and in urine. This figure shows the difference between patient A that take smaller size of water, 1 glass, with patient type B that took 4 glasses. Look, if the body hydration of the patient is not controlled, the specific hydration will affect the specific gravity, and it will be 1.015. Compared with the patient took a larger volume of water, it will be 1.005. So we have to remember to test the tubular reabsorption process of water, we need to control the hydration of body. Patient should not take excess water for the evaluation of tubular reabsorption, because excess water will be excreted in urine, and this will dilute the solutes, and we will have a less concentrated urine for the evaluation of tubular reabsorption. There are many tests in laboratory that can be used to evaluate tubular reabsorption. We have a test called overnight deprivation of fluid. So the fluids will be restricted for the patient. Patient will not be allowed to take water before or during this test. So after dinner, overnight deprivation of fluid for 12 hours. So patient will not be allowed to take water for about 12 hours. During this time, the patient urine osmolality will be measured, and if the urine osmolality is above 800 milliosmol or higher, this is what the normal. So any patient is not allowed for the access of water. His urine should be very concentrated, more than 800 milliosmol or more. If the urine test is abnormal, this means it will be less than 800 milliosmol, the fluid restriction will be done for another 2 hours for confirmation, and both urine and serum are collected. Now, for this patient, we will have the ratio of urine to serum of osmolality. If the ratio is 3:1 or more, this indicates normal tubular reabsorption. If the ratio is less than 3:1, this indicates an abnormal pathway, and this indicates that the kidney is not able to reabsorb solutes normally. Let us repeat it briefly. The kidney can be evaluated by tubular reabsorption using a test called overnight deprivation of a fluid. The patient is not allowed to take fluids for about 12 hours. After 12 hours, if the patient has a concentration of urine with urine osmolality 800 or more, this is normal and this is good for tubular reabsorption. If the patient has less than 800, this is abnormal. To confirm that this is abnormal, we need to wait for another 2 hours of water deprivation. After the 2 hours, we have to evaluate the osmolality of blood and in urine. The normal should be more than 3:1. This is the normal. If the ratio was less than 3 to 1. This means urine osmolality is equal or near to the blood osmolality. This indicates the loss of the kidney ability to reabsorb solutes and loss of ability of the kidney to concentrate urine. So this test is very effective to evaluate the ability of kidney to concentrate urine and tubular reabsorption. Let us have this figure 3 to 15. You can use the test of water deprivation to diagnose some endocrine disorders. So the test is done for a patient has a polyuria. This is the first thing. Urine osmolality you always is less than 200 milliosmol. This is very diluted urine always. And urine to serum ratio of osmolality is 1 to 1. The second step we will do, what we said about, is the fluid restriction. After fluid restriction, if the urine osmolality is less than 800 and less than 400, and urine to serum, the ratio of osmolality, again 1 to 1, this is abnormal. We said before that the normal is a 3 to 1. This is the normal. So this patient has a problem in the kidney ability to reabsorb urine, and this is related to what? To ADH endocrine function. In ADH challenge test, the patient is given ADH intravenous. If the urine osmolality become more than 800 milliosmol and the urine to serum ratio 3 to 1, and yani it back to normal, this means a problem in the ability of nervous system to produce ADH. The patient has a low ADH in the blood, and this case is called neurogenic diabetes insipidus. If the patient after injection of ADH still has a 400 milliosmol or less, and the osmolality of urine is low, 1 to 1 to serum, this indicates that the ADH may be normal or high. So patient may have normal ADH or even high ADH, but the kidney has a problem to respond to ADH. There are a problem in receptors, in physiological function of the kidney to respond to ADH, and this is called nephrogenic diabetes insipidus. We will take more details about this in endocrinology, but you have to understand, any patient have a diluted urine after restriction of water should be evaluated for ADH function. After injection of ADH, we can discriminate between nephrogenic and neurogenic disorders. So this is our lecture for today. I hope you can understand the items. You can send any question. I am ready for any discussion, for any detail, until we start the live lectures. Mostly we will have next week a live lecture at the time of lecture from 10:30 to 11:30 Wednesday. But until this time, you have to understand this lecture, to read what we have studied in the lecture room in university, and always prepare yourself for a quiz to evaluate your understanding of the course.